Everyone, myself Dr. G. Krishna Naresh. Today I will be talking about stiffness after ACL surgery. Speaking about stiffness, stiffness is like any loss of motion when compared to the other leg as a control. To quantify this, flexion less than 120 degrees or extension loss of 5 to 15 degrees can be called as a stiffness. It will cause more loss to the joint, and the damage also will be very severe as we thought after ACL. See, this is a very important slide. I also learned a lot of things about this slide. Previously, as everyone know, there are a lot of incidents and predictors, like females have more incidents of getting stiffness after the surgery, time interval after the surgery. If you do early, the stiffness will be more. Graft type if you are using, it can cause stiffness. Any other surgeries if you are using, like concomitant meniscus or any other things, multi-ligaments. But this recent paper which is published by Bing Wong et al. In 2020, they have mentioned about a meta-analysis. In this they have told about that only female and multi-ligament injury are the incident and predictors for stiffness. The remaining things are not of much importance. Only post-operative rehabilitation is of utmost importance for cause of stiffness. Again, there are a lot of biomarkers like IL-1-6 and lot of other things which can help us in predicting the stiffness. These kind of genetical and biomarkers are more in a blood workup when you are getting a ACL patient, but these are of very high cost. What are the causes of stiffness? It can be divided into central factors as well as local factors. The most important thing is arthrogenic muscle inhibition, which we have to know of everything. Like arthrogenic muscle inhibition is like lack of joint extension, and quadriceps contraction will decrease. It happens at multiple levels. It happens at the spinal level, it happens at the local level, and it happens at the brain level, and everything can cause, and it will become a vicious cycle. Joint injury will cause arthrogenic muscle inhibition, and again it will cause muscle weakness. Again it will go into a vicious cycle, and we have to break it at multiple levels to get back the normal mobility after a ACL or any joint injury. And this is the mechanism of action, how there is the arthrogenic muscle inhibition happens. And if you can see here, the swelling pain and differentiation, and this inhibition, this you have to inhibit, and the motor pool has to be again activated, and the quadriceps has to increase, the neuron engagement has to increase, so that the quadriceps will again recover. And the second, this one we can see there are different levels what the arthrogenic muscle inhibition is happening. Like we are at the spinal reflex pathway level, and above it is like a brain level, it will be caused by neuroplasticity. Different kinds of modalities are helping, and this will more go into a rehabilitation side, so I will try to postpone it. And one thing I have to maintain here, and I have to press here, that the exercise therapy is the only thing which will affect the arthrogenic muscle inhibition and maintain and come back from the arthrogenic muscle inhibition at all levels. There are different grades, like grade 0 is normal, grade 1 where the activation of VMO in few minutes, grade 1B where the refraction time is more. When till grade 1 only physiotherapy will be enough. When it comes to grade 2, the reversible will be there of VMO, but it needs more of correction with other modalities. When it comes to grade 3, it will be like a more of damage and more stiffness, which requires surgery for that. So as I told you, grade 1 it will require only simple assistive exercises. Grade 2 it will be like stimulation therapies, and grade 3 surgical interventions. Coming to local factors, there are different local factors. We can divide it as anterior and notch and posterior factors. Different things, mostly I can say it like adhesions and See, these are the anterior adhesions we can see in the patellar region, under the patella or in the lateral gutter. This can cause extension deficits. These are the posterior capsule tightness which can cause posterior flexion as well as extension deficits. Treatment plan, when you are seeing whenever there is a post-surgical adhesion, only loss of flexion, arthroscopic anterior adhesiolysis can be done. Only loss of extension, it will be because of notch or anterior adhesiolysis. So we can do that. If there is both flexion and extension, we have to do both anterior and posterior adhesiolysis. This is a video of doing anterior adhesiolysis. We are trying to remove the anterior undersurface of the patella adhesions in the suprapatellar area, and we have to remove the lateral gutter as well. This we are trying to remove. This is a posterior part. We enter into the posteromedial part of the compartment through the medial modified Gilchrist portal, and we cannot see anything, but we have to keep our shaver towards the scope, and so that if it goes away from the scope, there will be damage to the neurovascular structures, and slowly you will start removing the capsule and try to remove from medial to a central part, so that the neurovascular structures will be at the center, so you will give more movement and more space it will be there, and try to remove the posterior completely. And if you can see, we are trying to touch the posterior gastrocnemius. I am able to palpate with the shaver, and that is the end point when you are removing the posterior adhesions. See, the take-home message is stiffness of ACL is a multifactorial thing. Preoperatively, as I told earlier, female gender and multi-ligament injuries are only the associated stiffness. Biomarkers will help. AMI is a vicious cycle. You have to break it by exercise. Surgery requires removal of all adhesions from anterior to posterior. Don't try to go into all the compartments and remove. Mostly you will be try to remove anterior, notch as well as posterior medial. Posterolateral will be very less. Thank you.